Thank you very much, and thank you also for the invitation to speak in this meeting. While I was preparing my talk, and I realized that I gave almost exactly the same talk last year, and I went on Isvog on demand and saw my talk and said, "Oh my God, I will not give the talk again." So the issues, either I could have told you, please look at the website and have a longer coffee break, or I will provide the same message but with a new talk with different images and with some new thing I want to emphasize. The question was, and I changed the title, is still ultrasound needed in the age or the era of NIPT? And I asked, in the age of what? NIP what? What is this? For me, the question should be, do we really need NIPT in the age of a high and very good ultrasound technology? So this could be my question. But let's say we have a big problem, and the concern of Trimestre 21 is the rate of high positives. And we are now having, let's say, the back part of the 25 years of nuclear translucency screening, where we're telling that invasive procedures are so dangerous, and this is why an NT screening is a good alternative. Now where the geneticists say microarray is such a huge and a big chance, we cannot convince, let's say, patient to return and to think the other way. So I tried to show you why is ultrasound important, especially in the era of cell-free DNA. And the question at the beginning, and I will not give you an answer to this because this is depend on your patient and on you. Should NIPT be performed before comprehensive first semester scan? Should NIPT be performed after a comprehensive first semester scan? Or should be as a screening without or instead of first semester scan? And I have patients coming to see me and say, I don't care of a disease like Down syndrome, but I want to see if my baby is healthy. I want to be prepared as early as possible and to this condition. And the learning objectives are, let's say, similar in many talks. So first is that NT is only part of the animal scan, that the systematic examination, I will show you how I do it, increase accuracy, but we should also emphasize that some anomalies are not detectable or an early gestation or have a potential to be detected. And we have enough time for decision making, and high resolution ultrasound is achieved with transvaginal scan or with special probe. Until recently, here's the course. First semester screening was a synonym of screening for aneuploidies. And this is why probably the question was asked, do we still need? And I told in many of my talks in the past, if you are still selling the first semester ultrasound as a tool for aneuploidies, you will lose as soon as NIPT will take over. And this is why people now understand that first semester screening can be screening for aneuploidies, can also be in addition a detailed fetal ultrasound. And my message in my talk is one of the messages that we spent 25 years establishing an excellent level of first semester ultrasound. I'm observing that we are losing this battle because people are still assuming I don't need ultrasound because NIPT is normal. And this is why don't give up for NIPT and focus on the early anatomy assessment and predict pregnancy complications if you use, the algorithm of Kipros for preeclampsia and other things. And interestingly, I learn also from some patients because I speak occasionally with them discussing on why they are doing what. And one medical doctor told me at that time, if I take 300 euro to perform an NIPT, I can take additional 200 or 300 anyway to know as early as possible that everything is normal. Especially women in some situation, in some positions, before they go out and they say, I'm pregnant, they want to be sure 13, 14 weeks, there is no severe problem. Before telling as a CEO in a company or to tell their children that I'm pregnant, they want to show everything is normal as much as I could tell you as early as 13 weeks. So don't consider NIPT as an alternative, but as an addendum. I prefer if they do the NIPT, so all stuff on, the nuke and the nasal bone is little small, but, and the nuchal is borderline, and so are done, and you can start working on the anatomy. And how are anomalies detected in early gestation? In my experience, there are 4 groups One group is the direct detection. You see it's a gross anomaly. You see the omphalocele here. The second group is you have some hints for the abnormality. For example, the thickened nuchal translucency. It can be also a measurement like the crown rump length or the different size, the abdominal size and so on. But in general, until now, it was the thickened nuchal, and you start working on, it could be cardiac anomaly, it could be trisomy, and so on. And interestingly, a group family history. So you have a previous pregnancy in a group like, for example, Meckel-Gruber syndrome, having autosomal recessive trait, or you have a parental translocation, and you know that the anomaly can be seen in early gestation. This is the group. And you have more and more, because you are able to do the scan in these patients, the group of systematic examination, so screening. And this group, believe me, is increasing because these are the girlfriends, the sisters, and the neighbors of these patients. They say, you know, you were the doctor, you saw in my neighbor that at 12 weeks there was something wrong in the heart. Can you do it also for me? And then you cannot say, no, I cannot. And then you start working in a way to work efficiently. How to do it easily in a low-risk population with a high efficiency. And what we have to learn, and this is a message for you at the beginning, my first message is forget the one-glance diagnosis you know from second trimester, because you will fail. I failed, but I'm telling you where I failed so that you don't need to do the mistakes again. So there is normal fluid in real agenesis. There is no lemon and banana sign in spina bifida. There are no big cystic lesions we know from the cystic kidneys and lung anomalies and echogenicities and so on. We don't have polyhydramnios or oligohydramnios so rarely, so not a typical sign. And the biometry deviations are within the range, but slightly deviated. So you need to have a feeling for biometry in early gestation, which is not like all bones are outside. They are in the lower range, and you say, wow, but it looks abnormal. So there are different things, but this is something you have to relearn for trimester ultrasound. And the second message is try to examine systematically. Don't examine and watch the baby, because you are, most of us, misled by the fact that abnormal fetuses should have a thick nuchal, which is not the case. You may have a normal nuchal, but have no arm, no legs, single ventricle, and so on. So forget that the nuchal is the key for all anomalies. It is one key for a group, but if you don't examine systematically, you will not see. And I will go with you through all these things. Let's go to one study published by Argyro Singolaki. I like the study very much because it shows us following. In fetuses in a large database of Nicolaides and group having no chromosomal anomalies, and they examined here 45,000 in their different labs. I think it's a London study in different labs. They had anomalies detected in 100% of the cases, like anencephaly, holoprosencephaly, omphalocele, gastroschisis, megacystis, in all cases. Okay, so in other words, this is something every one of us will see it. But what about the other way? So the other one, so major heart defects, half, hand-feet anomaly, also 25 to 50% deformatic hernia. And this group here, spina bifida, clefts, and renal defects are really less than 10%, was 5, and so on. In other words, the challenge is not to detect these. The challenge is to detect these and to teach your referral doctors that it is easy to see these if they magnify the image and look at the baby. So the first, and I will go with you plane by plane, and I will call it first semester done easy, is, for example, this plane. When you start your examination, you magnify the image, and you keep 30 seconds watching. The patient is so enthusiastic. They see the baby. They are happy. And you check within this image saying, I measure the CRL to see if there is no growth retardation or no discrepant size, because an abnormal growth could be a hint. The nuchal looks normal in this region. And I see the head, I see the face, I see the abdominal wall, I see the bladder. In other words, the masts are seen, ruled out. One plane, simple to measure the CRL and think there is no anencephaly, there is no ectopia cordis, there is no body stock anomaly, no severe hydrops, there is no abdominal wall defects, there is no megacystis, no holoprosencephaly as much as I can see here, there is no abnormal placenta. So you have roughly, the masts are within one view, but you need to have this plane. And then you see within one plane, you can check all these anomalies. You see here the absent head, you see the abnormal face in holoprosencephaly, the megacystis, and the short the abnormal shape in the case of sacral agenesis, but similar could be also the triploidy. So you see that their proportions are abnormal. So this is something you see while you are measuring the CRL because you are good. Then you magnify the picture because you learned 25 years long to measure the nuchal, and I will always measure the nuchal even if I have an NIPT and even if I have an CVS, because I want to document that at this stage it was normal. Document, put it, you don't need to calculate the risk, but you document. And we have focused on, for years on the nuchal translucency on one hand, on the nasal bone on the other. But we have a little bit more information because we see the forehead, the mandible, the maxilla, the mouth, and the mandible. And we see also in the posterior brain also other structures like the midbrain, the brainstem, and the fourth ventricle, and the cisterna. So why not to use this plane to focus on the face? And this is images. You can see straightforward that they are abnormal. So by magnifying the image of the face, and this is the second plane I will do, because we will anyway try to measure the nuchal translucency, you see that the faces are grossly abnormal, and this is something everyone can detect, from epignathos to acrania to frontal encephalocele. But if you remember the table, 5% detection rate of facial clefts. Can we use this plane to detect facial clefts? Yes. And this was the concept of the maxillary gap we published 2 years ago. It means that in the plane you are watching the nasal bone and the nuchal translucency. This is the maxilla. You will always see the maxilla. In cases of clefts, it can be partly absent anterior, posterior. We may have a protrusion. So you can see an interruption here, and this is a hint simply seen in the plane you are using to measure the nuchal. So you see here the absence of a part deficient palate, and then you can rotate the transducer to get the facial view and then work on it. So the plane used for nuchal can also be used for cleft, and also can be used also in cases where you see the mandible here posteriorly shifted in case of macrognathia, and you see some of the papers published in this field. This was the concept of maxillary gap to find a simple hint for cleft. Of course, I'm rotating the transducer to have a view to the face, to see the eyes, but yeah, many people may not do it, but almost always the abnormal face is associated with the abnormal profile. Then comes the other concept of the posterior fossa, the concept we published 8 years ago on the intracranial translucency. The idea was that if you see in this normal fetus, and if there is a spina bifida, the fluid present here, not only in the lateral ventricle, but in the posterior fossa, will disappear more and more, and which leads, since the 6 and 7 week gestation, to a posterior shifting of the brainstem and downward displacement. And this leads to an abnormal shape of the posterior fossa, but you need to teach people to watch this condition. So in other words, the issue is that if you train people to look at the structure here, you can get more information, and you may detect on the simple plane used for the nuchal translucency the cases with the spina bifida. So you can use the brainstem relationship to the distance, you can use the 3 lines, you can use the area, you can use many things, but I want that you are trained to look at these structures, and you see in abnormal cases you have large brainstem, you have a small amount of fluid here, you don't have the typical 3 lines, and this is a hint, simple hint seen in the mid-sagittal view. And this is the only video I will show in my talk today. So this is a case here I saw last year, and a screening for maternal age for nuchal translucency, which was normal, but I missed to see any typical lines and fluid here. This was the abdominal probe. I used then the linear probe to see if I see anything. I was surprised because I haven't seen anything else. Then I went transvaginally. You see here some fluid, but there is a thickened brainstem, but honestly, I haven't seen any spina bifida here. So I was surprised that it may be my first false positive sign, but I had to wait until the baby turned. And then when the fetus turned, you see it's 13 weeks, and I had to wait. And then at the end, I saw that this was a myeloschisis, very tiny here. And in this position, you can see the spina bifida here. I'm sure 100%, 103% that I would have missed this condition on a screening condition if I have not learned to look at the brain. So if you think I am good, what we did in Berlin, we went to the university, we put all my competitors in one city together. We sat on one table, some 20 experts, and we said we can now measure on every fetus. We ran a study over 2-3 years. 16,000 were scanned. All cases were detected. Some had a delay in detection. We were suspicious, and at 16 weeks could be confirmed. So it works if you train people to do it. It's not the occasion looking to the posterior foci. It should belong to your scan as much as nuchal translucency. Imagine a 20-year-old girl has the same risk of having spina bifida than Down syndrome. Why you measure the nuchal and not the brainstem? But in the meantime, we have other signs as well. So today, you cannot discuss on first semester without looking to the different signs, the facial angle, the dry brain, the area of the fluid, and so on. But while looking to this region, you may detect cases where the fluid is not reduced, but increased. These are different cases. And what we learn in these cases is that it could be a transient finding, but often, especially if you have additional signs, like here you see there is no nasal bone, there is maxillary gap, there is dilated, there is thick nuchal. It can be aneuploidy like trisomy 18. It can be a Blake's pouch developing later. Then the Walker condition, cephalocele. So you need to offer invasive. You need not to let the patient be anxious, but you need also a follow-up, ideally at 16, 17 weeks. Second plane. Third plane, I will opt for the BPD view, and I will encourage you to measure routinely the BPD because you oblige yourself to look at the head. And the more you do this, the more you will have a look inside the brain. You see the ossification, the falx cerebri, the lateral ventricles. And then with this view, only by looking to the BPD, you will detect holoprosencephaly because you miss the line. You will detect interruption in the ossification, which is cephalocele. And you see occasionally cases where there is some fluid, more or less, and I will recommend you to measure the BPD and to compare with values because it was reported that small BPDs are found in holoprosencephaly, Sepulveda and co-workers. Spina bifida shows also small BPD, not out of the range, but in the lower range in comparison to other values like CRL and abdominal circumference. Our study and the study by George Haddad and co-workers, cephalocele because part of the brain is outside, but rarely will have a larger brain. I had last week a case with a larger head because of thanatophoric dysplasia. They are at the upper range already at 13 weeks, and in triploid you have this discrepancy between the head appearing large in comparison to the thorax. So the measurement per se has two aims because you can use the measurement and compare with other values, but also oblige people to look at the brain, what's going on here, why there is no fluid, because there is spina bifida. Not all cases, but some. And then comes the point where you think it's a ventriculomegaly. Ventriculomegaly, large ventricles, if you measure, they are all in the normal range at this stage. There are reference ranges. So in ventriculomegaly is today defined until 14 weeks as an abnormal relationship between the area of the choroid plexus in comparison to the area of the ventricle. In general, it is, if it's less than the half, I will consider it as so-called ventriculomegaly. So I will not tell the patient I'm afraid. I will do the same. In this case, it was a typical aqueductal stenosis with dilation of the third ventricle. In this case, it was later on Walker-Warburg syndrome. But I will do the same exactly. It can be transient. It can be aneuploidy, offer the same, have a follow-up. But it can be also early sign of brain anomalies. We saw it also in Walker-Warburg or in some encephalosynapsis. In aqueductal stenosis, there are a syndromic one and isolated one, but also late brain anomalies like agenesis corpus callosum and others. So focus on this sign, but first for this condition, and second, to look at the brain up to 16, 17 weeks, and not to tell the patient there is hydrocephaly because the measurements are not working yet. Then we come to the group which was considered for years the most difficult one, which is the cardiac defects. Here we have indirect hints, which can be used like thickened nuchal, tricuspid regurg, ductus venosus reverse flow, and abnormal cardiac axis. But I support personally the thesis of a direct cardiac examination, the 4-chamber view, the 3-vessel trachea view, and this is the next plane I will recommend to do. So in the upper thorax, teach people to use the color Doppler to demonstrate the filling in diastole and the systole of the 3-vessel trachea view. Here, in my experience, not the experience of the user the problem is the setting of the machine. So ideally, I wish that the companies have a special preset for this part, that people can do it rapidly without a lot of energy because they are fixing the knobs. You cannot take a second trimester preset for a first trimester. You need a completely new one, but you need less energy because you see then the filling. With this simple plane of the 4-chamber view, demonstrating 2 chambers, you can straightforward see that there is only 1 chamber seen here, or mixed of blood in these cases, or a discrepant chamber, but you can also detect or depict a severe tricuspid regurg. The 3-vessel view is even more efficient, and there are enough publications published in the White Journal and Prenatal Diagnosis on these cases, where you see the abnormal size, the reversal flow, and the right aortic arc, the single vessel. So you have signs known from second trimester you can apply in first gestation. Now, because you are looking to this plane, you are also looking to the chest. And if you look to the cardiac axis, you may see the abnormal shifting of the heart in left and right diaphragmatic hernia. But believe me, this is for the big expert. You will miss almost all cases of diaphragmatic hernia because they are really difficult to detect. The stomach is going up, but it's not yet close to the heart. So don't be disappointed. There is a trick you have to look at in longitudinal view, but there are cases you may see also abnormal, like the short ribs here. They appear in skeletal dysplasia after 13 weeks, in my experience, or some unilateral effusion being rather norm, let's say a variant of the norm in most cases, or bilateral seen in aneuploidy. Then we come to the abdomen. In the level of the abdomen, we do in general, all of us, more or less the typical 3-4 planes. One plane is the level of the stomach, the other is the level of the anterior abdominal wall to rule out defect in this region. The third, to demonstrate the filled bladder with the 2 umbilical arteries. And if you want to look at the kidneys, I will show you later on why. The best view is the frontal view to this one. What I do here, I will not discuss a lot about later on, is I do a plane where I look at the kidneys. I tilt the transducer to see the diaphragm. I return back to see the spine. I have 3 informations within one plane, or moving anterior and posterior. So for the abdominal wall defects, this is obviously seen. You remember the view of the mid-sagittal one, but this tiny one is not always so clear seen. And in some machines, you may think this is the umbilical cord and not the bowel. So be careful if you have a suspicion. Scan with the high-resolution probe or transvaginally, and you can see more defects. Then comes the group of the megacystis. Megacystis is important not to make a diagnosis of the cystis per se, but to measure, because cases having 15 millimeters and larger, as published by Kypros group, are either aneuploidy or uropathies. In the cases less than 7 millimeters, you can forget them. And in this group of the group between 7 and 50 millimeters, 20% aneuploidy, 10% uropathy, but in follow-up, 70% are going to be normal. So we will not say it's megacystis, we will describe the size of the bladder. But if you see a megacystis, it can also be something different. It can also be other cyst, like a hepatic cyst. It can be also the bowel, and you see here the dilation of the bowel. So it can be also a kind of enterolithiasis you will see later on in gestation. So in these cases, be careful. Not all cases appearing as megacystis are megacystis. You need to scan accurately and check the kidneys in these cases. By the way, the kidneys, you can see them clearly. I try to have these images on the routine, but honestly, if there are cases on screening, the bladder is full, I don't see the kidney, so I may sometimes leave it, but because renal anomalies of the kidneys are rarely detected in early gestation, but if any, the typical one detected are the polycystic kidney in Meckel-Gruber syndrome, not in the autosomal recessive group. These ones are not yet abnormal. They will start being abnormal after 20 weeks, 25 weeks, they will start to be large and echogenic. So if you have a recurrent case, you have to do a CVS, because you know the previous case. You cannot rely on the size and the echogenicity. But what I personally consider as a challenge, and I think it works, is if you don't see all over the examination the bladder full, I will continue and check for it. This is why what I do first, sometimes even before the nuchal, is to see if the bladder is full. Because if I have 20 minutes scheduled for a patient or half an hour and the bladder is not full, I will not leave the patient go before seeing. So if I see the bladder full, I will document it. In this case, the bladder was empty. The umbilical arteries are close to each other, and then you see the fluid is normal because this is still placental fluid. And you see there is no kidney, no vessels, but I was afraid of a pelvic kidney and transient empty bladder. I told the patient, we will wait until 16 weeks. Because I told her, believe me, you go to the hospital, no one will terminate 13 weeks with normal fluid because there is no kidneys. They will consider me as crazy. We will wait. And 16 weeks, it was oligohydramnion as expected, and she decided not to continue. So it is a lethal condition, has a normal nuchal, normal ultrasound appearance. The only hint is the typical full bladder and typical kidneys were not seen. So try to work on it. And if you work on looking to the kidneys routinely, you will detect cases like a pelvic kidney, typically when you have a single umbilical artery, for example, or a horseshoe kidney, typical hint in trisomy 18 or Turner syndrome, or if you have a family history. So for me, these are the groups I look for, these signs. And I come to the end with the skeleton. The skeleton are the limbs and the spine. This is the best time you look at the limbs because you can never see the hands always open and the legs so nicely seen as in early gestation. And as I told you before, I'm trying more and more to look at the spine on a routine, either in a longitudinal view to see the shape and the size and so on, and in the frontal view, when I'm looking to the kidneys, I go a little bit out to demonstrate the spine. And the patient realized, oh, the spine is normal, there is no spine bifida. I said, we cannot rule it out in early gestation. We need to have a second trimester scan because you have also closed spine bifida, and all signs do not work. So I tell them it looks nice, but we have to be careful. And believe me, for the skeleton, for the hands, for the spine, use more and more 3D because you can show the patient both hands. Believe me, often the question comes, oh, this is the right hand, this is the left hand, and they ask, are you sure these are the different hands, or did you show me the same hand twice? Yeah. You know, women have a lot of hormones at 12 weeks, and and when decided to have a scan and you are doing it rapidly, so you have a view. Sometimes they are ugly. This is the best images. I will not show you the bad 3D images done abdominally, but they see the proportion, they see the legs, they see the limbs, and in previous history of abnormal limbs, like in one of these here, it was in trisomy 18 with the radius aplasia. I tried to demonstrate as early as possible that the limbs were normal, and for the one having previous history of spine bifida, I start showing them the spine on 3D, that they see that at this stage everything was normal. And for the spinal assessment, as I told you, we can have a look to spina bifida, which is it's like this, easy to see because you know what you are looking for at the level of the head. But here also, sacral agenesis, I'll show you a case, and hemivertebra is really a big challenge. But in that case, it was trisomy 18, and I could see it, but I'm not sure I see it in all cases. And this is why I'm working more and more if I have a fetus which looks very short. Could be a hint. Rarely it is like in a book. The patient comes, I am diabetic, I never had a follow-up, please look at the pelvis. This is not the way. The way in general is she comes because the doctor says the abnormal size, I'm not sure, it is small, it is not growing. And you scan here and you see, oh my God, the spine stops at the level of the kidneys here. And if you look at the CRL, you see this body is too short for this head, and this is the spine interrupted here, and this is the pelvic bone. So it is a kind of sacral agenesis or spinal dysplasia. And for the limbs here, an example, you can have amputations, amniotic band syndrome. It can be isolated club feet, rarely seen first trimester. A typical radius aplasia, one unilateral, lateral, bilateral, aneuploidy in syndromic conditions. You have short limbs, you have abnormal fingers. And you see, for example, such a case here, short femur and short limbs. What is this condition? Nuchal was thickened. So what would you do next? Next, I will always go to the head because the most common conditions are either osteogenesis imperfecta or thanatophoric dysplasia. Osteogenesis has no ossification except the occipital bone. You see, there is no bone. Where's the bone? You see here, but where if you go to thanatophoric dysplasia, you have more bones, you have larger head. The shape is almost changing, and you have other, even the ribs may be abnormal. And typical in in osteogenesis imperfecta is that the bones are different on the left and the right side, where in other diseases they are symmetrical similar. So this is one case, but I could show you also other cases. But even if we are very, very good, keep in mind that there are conditions we cannot detect in early gestation, like brain abnormalities until now. I say not yet, lung anomalies, and some renal anomalies, especially the one associated with cysts, and some cardiac anomalies like tumors and, let's say, obstruction things. Now, I showed you all these things, and because people are asking us about how to do it more and more, so this systematic approach is just published in our, here, the first time issued book. You can see it at one of the booksellers, so it just appeared 2 days ago. And my message at the end is, I have no problem that you can do what you want, but you have to tell the patients with NIPT you see 2 diagnoses, 3 diagnoses. But with ultrasound, if we spend a lot of time, if we do it systematical, the CRL, the head, in mid-sagittal, the BPD, the thoracic view, the abdominal view, and the limbs with the spine, you can have many anomalies detected. And I hope I was clear enough to tell you this is my message, and this is the counter message to what we heard today. Thank you very much.